Good morning, everyone, and welcome to the last series of the virtual training under the PANCAP-CVC multi-country grants, and which are facilitated by PAHO. My name is Sandra Jones, advisor with the Pan American Health Organization at the Sub-Regional Office in Barbados. Today's training, monitoring of HIV/STI services for key populations, will be facilitated by my colleague, Monica Alonso from the PAHO headquarters in Washington, D.C. Over the past weeks, we have looked at high-impact HIV prevention services for key populations. In today's presentation, the focus will be on the monitoring of the continuum of HIV/STI services for prevention and care for key population. Before we start today's agenda, please allow me to review some housekeeping announcements. Your mics are muted, and during the discussion, they will be opened following the presentation, allowing for questions and comments. Kindly press the raise hand icon and your mic will be opened for you to speak. The training is being recorded and the link will be shared by PANCAP. It will also be uploaded to the PANCAP and PAHO websites, as well as other social media platforms for the benefits of persons who could not have attended the live session. Also, you will see on the screen below handouts the KP monitoring framework for which this presentation is based on today. A copy of the presentation as well as the framework will be shared through PANCAP. I will now call on Dr. Shanti Singh, who will be making brief remarks on behalf of Dr. Rosamond Adams, the Director of PANCAP. Dr. Singh, you can go ahead, please.
Thank you very much, Sandra. Good morning, colleagues. Good morning, Dr. Alonso. I am pleased to be here with you this morning and to make some opening remarks on behalf of my director, Sandra said, Dr. Rosamond Adams. We are, and by that I mean PANCAP, we're pleased to collaborate on this training series and indeed to collaborate on this final training as part of this overall series on monitoring of HIV/STI services for key populations. I think we know a few things. We know that in the region, we have an HIV prevalence of 1.1 with an estimated 330,000 people living with HIV. We also know that when we look at a 1990 cascade, that we've made progress, but at the same time, we are a little bit below the global average as it relates to the 1990 cascade. What we know too is that in many of our countries, the HIV and STI prevalence among key populations are significantly higher than that of the general population. In some of our countries, for example, HIV prevalence among transgender persons is reported to be greater than 50%, and for MSMs in some of our countries, greater than 25%. What we also know from the last GAM report and from previous GAM reports is that more than half or almost half of the new infections in the region, and specific reference to 2019, occurred among key populations and their sex partners. Certainly over the years, I think our countries have responded and have really delivered tailored and targeted interventions for key populations. This has resulted in many more key populations accessing HIV prevention services, STI prevention services, testing, linkage to care, and treatment services. This training today really is focused on how do we strengthen the monitoring of services for the key population community. And I think it's really very important. I think we are really poised at this time of the epidemic to collect and use more granular and population-specific data for decision making and program planning. We should, as a region, in fact, move towards reporting on the continuum of care cascades for HIV and STIs for the different key populations that we have. We should, for example, be collecting data and reporting on prevention cascades. But more importantly, I think the information should be used to strengthen our responses. So if we're to continue to make progress in the epidemic, we must reach and deliver prevention treatment services to the hard-to-reach communities. And this, in our case, includes the key population. I think, therefore, comprehensive, systematic, and timely monitoring and use of data is really critical for us to understand the epidemics in these populations and really understand how to best respond. I think, therefore, that today's training is really important as we conclude on this series of training. And I trust that it will be beneficial to all of our participants present with us this morning. I wish to thank PAHO for this really important collaboration. Thank you to Sandra Jones for being a really responsive partner to the partnership, and to our presenter, Dr. Monica Alonso, who has always been supportive of the work that we do in the Caribbean region. Thank you for leading today's training, and I wish us all a very productive training with Dr. Monica Alonso. Thank you very much, Sandra.
Thank you very much, Dr. Singh, for those remarks. And we hope that this is going to, following this presentation, that this is going to be the start of which we could advance the monitoring of the HIV and STI services for key population in the region. So now, without any hesitation, I will now turn over to Monica for her to make her presentation. Monica, I turn over to you now.
Thank you, Sandra, and also thank you, Dr. Singh, for those welcoming words and the invitation from PANCAP to share some of the thinking and the work that we have been conducting that I think will be very useful for the Caribbean. This is a piece of work that we have been carrying out and working on over the last few years, and it's important to actually build upon it with the experiences of the countries, in this case of the Caribbean. So whatever I'm going to present, it's something that is not set in stone. It has to be very operational and useful. It cannot stay in the clouds. So if in any moment you see that it's something that's in the clouds and we cannot use it, then it would be great to understand your perspective and even have a discussion on this. So in the next few minutes, I will be explaining what we are addressing with, or what we think about the monitoring of HIV STI services for key populations. And here are some of the contents of the presentation. First, I will briefly address some thoughts related to ending AIDS by 2030. Why focus on key populations, which we all know, and Dr. Singh also mentioned the great burden of new infections among key populations in the Caribbean. But here's another slide with a little bit a reminder and refresher. An aspect of how to consider key population for monitoring, because when you monitor, that's the devil is in the details. So you have to have very clear parameters and very standardized parameters to actually get good data. And then lastly, I will present the PAHO framework for monitoring HIV STI services for key populations. So here, this is just the reminder of where we really want to be. In blue It is the line of HIV incidence per 1,000 population in Latin America and the Caribbean over the years. And we see a little bit of stagnation in the last years, although I must say that, and we're all cognizant that new infections in the Caribbean have been going down at a greater pace than in Latin America. So, you know, kudos to us. But where we really want to be is the gray points. So it would be the little dotted light blue line, which is much, much lower. So we still have a lot of work to do to actually meet the targets of ending AIDS by 2030. That is, they're very challenging targets. So here, we see the data that Dr. Singh was referring to of how key populations account for a very sizable amount of new HIV infections in the Caribbean. These, of course, are modes of transmission studies conducted by UNAIDS. So they're estimates, and they're only as perfect as the data that goes into it, et cetera. But it is important in itself to see how more than half of the new infections arise or occur in key populations or their clients or partners. And also an important aspect that we all are very aware of, and I just wanted to put in the slide as well, that these populations face important barriers in the access to health services, and are also, they suffer stigma and discrimination in our communities. So these are maybe the highlights of why we need to have this special focus. So what is considered a key population? Here in orange, I have an extract of a text from UNAIDS. And so this is from several years ago, and we know that these are people that play a key role in the epidemic due to their specific practices that make them at an increased risk of HIV infection, and also the consideration of those legal and social contexts that accentuate their vulnerability and access to services. So what I want to point out from this, and it's very important for monitoring to have very objective and standardized components that we turn into variables. And so in the definition, it talks about practices, specific practices. So we are really not looking so much as identity and sexual orientation. That is different from a sexual practice. So for monitoring, we are looking at key populations by practice-based rather than by auto-identification, with the exception of transgender women, which is based on their gender orientation. But just to give a little quick example, a man that is a MSM, that has sex with other men, even in the definition, the way it's phrased, it's by the practice, not the way that person considers themselves. Their sexual orientation may be whatever it is, that's for them. But the practice per se is what will put this person at increased risk of HIV infection. So that is what we're going to be monitoring. Here we have a picture of what we, around the house, we call the PAHO monitoring framework for short, because the title is a bit long. It's a framework for monitoring HIV STI services for key populations in Latin America and the Caribbean. So we understand there's many monitoring frameworks out there. So if I ever refer in this presentation to the monitoring framework, this is what I will be referring to. This is the document that Sandra said will be also shared for all the participants. And in this document, there's several elements that I will be addressing throughout my presentation. So one of the first elements is just to make clear to everybody how to operationalize the key population variables. So what will be considered a person from a key population group, not you know, what I think of this person or the way this person is dressed. That doesn't reflect the practices that that person has necessarily, of course, because that's apart from the risk, which is based on the practices. So here we consider 5 questions that are very straightforward, very simple. This was adapted from what PEPFAR uses and is what we recommend to actually make the identification of, in our monitoring of key populations, much more objective and not subjective to the person that's collecting the data, which can vary from person to person. Here, and before going into the monitoring, I just want to focus on what are we monitoring. We need to understand what it is to be able to elaborate or define indicators to actually measure the important elements. We're not going to be measuring every single thing. So here I have a little bit of the continuum of care for an HIV negative person from a key population group. I didn't select the HIV positive because I think we're all much more familiar with the continuum of care for HIV positives through the HIV Cascade, the 90-90-90 milestones, etc. But the basic package of prevention services has a lot of different elements, and we won't be monitoring each and every component of that package. What we have done for this monitoring framework is take a few proxy services that will be the ones that we will be following through the continuum of care. That's one thing. Another element is that we are considering that HIV negative persons from key population groups also have health needs. They don't need to become HIV positive for them to really need a certain package of care. So what this means is it's not only that we give them a condom, we give them lubricant information and we test them and then we say goodbye. We actually want to incorporate them to services and offer them services throughout the continuum based on their needs. So first, here we would see HIV testing. The person should know their HIV status, and they would have initially these different tests. Of course, this is not exhaustive because if not, it would be very difficult to put all the services that a person needs in this slide. But as an example, we would offer them HIV testing, condoms and lubricants, screening for syphilis, hepatitis B screening, or the person may come requesting non-occupational PEP. And then also this is just a model. It doesn't mean that necessarily in your country, these are the initial services provided, because it does, it depends on the organization and the model of the services that's being implemented in your country. But this could be like the initial point of contact. Then we would want to link this person to a broader series of prevention services. So that person would receive a risk assessment. It's like, you know, when you open the clinical history and you ask them different questions to understand what their needs are. And that risk assessment is linked to PrEP eligibility as well. Then if for example, if the syphilis screening test was positive, that person would receive a confirmatory test and would receive treatment. And that person would receive a clinical assessment for STIs. And if there are etiologic screening tests available, for example, they would receive screening for gonorrhea and hepatitis B vaccination if they were negative. Then we would want to actually keep this person retained in services. So the follow-up time will depend on the needs of that person. For example, For PrEP users, it's established at 3 months. For non-PrEP users, every 6 to 12 months is what WHO recommends. Oh, and by the way, all these examples of basic services that would be included in the package of prevention and care are services that are recommended by WHO with a grade recommendation. The retention in services that can be at different moments, we are considering just for the effect of monitoring 12 months, but you could monitor at shorter intervals. So at 12 months, this person would be, again, receiving a service. That person would be assessed for their risk, because risk is not the same throughout your life. It can vary on different contexts. That person maybe would continue on PrEP or not. That person definitely would receive an HIV test, and that is the marker that we're going to use to say that that person is retained, and would receive those other services, as you see here on my slide. So what would be the endpoint? Similarly to the HIV care cascade, where the endpoint is a suppressed viral load, our endpoint here in green is that this person, which was HIV negative from the start, because we know that they received a test and they were HIV negative, that's why they're in this continuum of care for prevention, that person would be sustained HIV free at 12 months. We want that person to continue negative, and this is like our impact target of our services. Of course, all the services would be based on human rights, inclusive and free of stigma and discrimination. And we have some indicators based on that. So just a short comment on this assessment of substantial risk. I think you're probably very familiar, but just to mention that right now, the variables or the questions we're using to consider substantial risk are those that are linked for eligibility for PrEP. So here are the questions that are used and recommended by WHO to assess for substantial risk. Generally, I think that when a person is tested for HIV and you fill in a pre or post test formulary, generally these questions are asked, and they're fairly simple, right? So just to mention that. And here we have what we're proposing as the monitoring framework. So we have in red the HIV positive cascade that we all understand. And what we would be referring to is the disaggregation of that cascade by key population. And why would that be important? Well, just like you disaggregate by geographical area or by sex or by age group, also we're recommending the disaggregation by the different key populations of the results of the continuum of care within this subgroup. And that can provide various information with regards to possibly different gaps and coverage depending on the key population we're referring to, and will guide you to improve your services for the HIV positive population. So here in the first pillar, we have the key population, which would be an estimate, right? Just like for our cascade of care, the first pillar is always the estimate of HIV positives. So here we would divide that estimate into positives and negatives based on either your spectrum estimates, or if you have a prevalence study, you apply that prevalence and you get the HIV positives, and the subtraction would be those considered to be HIV negatives. We understand that this is a snapshot because HIV negative population is not something static. You can be HIV negative and then get infected. But if we're just so perfectionist that we can't accept that, you know, that, well, this is just a snapshot, then we wouldn't be able to work with this. So this is, we understand some of the constraints, but this is the, like, a model to work with. So among the key population, you would have those that were tested for HIV in the last 12 months, because that is a WHO recommendation that all key populations should at least be tested every 12 months. So you have all those that are tested. Some are would be positive, so those would go into the care cascade, which are the lined red section, and then we would have the negative, which would continue in the cascade for prevention. As I mentioned, we would have those that are linked to prevention services, those that are followed up after 12 months. Here, we mentioned followed up would be tested for HIV, right? So, of course, we would have some that might have turned positive, and that's that little slim red area above, I don't know if you can see it, the slim red lined area above the blue pillar. Of course, we want to have this as minimal as positive, but here we would see the sustained HIV-free at 12 months. Actually, this pillar should be as high as the one tested negative in the previous pillar. So yes, we are looking at it from a longitudinal perspective. We understand that this may pose some issues, but since we want to provide individualized service for each person, and depending on their needs, we think that the monitoring services are also capable of keeping track of these important milestones. Now, here we have an example of all the cool things you can do with this monitoring framework and this idea. And here we have an example of an HIV prevention cascade considering PrEP. And this is very important because you can show, if you monitor things in this way, you can see if your services are being successful, and you can show politicians and those responsible of deciding on where the money goes, the usefulness of your services. For example, here we have the first pillar, which are the HIV negative key populations estimate. Then we have in the second blue, dark blue pillar, all those tested for HIV in the last 12 months. Then we would have those linked to prevention services. We consider linked in addition to be tested, that person has some type of additional service. Like, for example, that person was screened for syphilis, that person had an anamnesis done, a clinical record history taking done, where that person was assessed for their risk. So here you could see in green the HIV negatives that don't have substantial risk. Then in dark purple, the HIV negatives that do have substantial risk that are not on PrEP. And in light purple, those that do have substantial risk that are receiving PrEP. And so all these people would be linked to services. Some, for whatever reason, have substantial risk but are not taking PrEP, and others are. Then after 12 months, you would see which ones continued in your service, and you would see all the people that are followed up, and you would be testing them for HIV, so you would understand which of these actually turned HIV positive. So you would expect the light purple, which are the HIV negative key populations at substantial risk that are on PrEP, to not have any HIV positive among them. You could have, that's something that you're monitoring, but it's important to show that. So in this example, I don't think anybody turned positive among the PrEP users. Among the non-PrEP users, but that have substantial risk, we see that an important amount, actually, and this is a fictitious example, turned positive, because our purple band here is much smaller, and we have this important number of HIV positives up here in red. And then among those that were considered not at substantial risk, almost the same number, but actually a few also turned positives. And if you evaluate that, you can understand how well am I detecting if that person has substantial risk or not, how well am I addressing that person's needs, etc. Because in principle, that person should have been remained HIV free, and if not, we should have maybe offered them more services or offer them PrEP. Another important element of monitoring these services in this way is the disaggregation by provider. Here we see the contribution for each of the pillars of services provided by the Ministry of Health versus and services provided by civil society organizations. And in our context, where a lot of the services for key populations are donor dependent, in the funding is donor dependent, it is important for, as the donors go away from our region, that we can show what is the contribution, the real one of the contributions, excuse me, of civil society in the prevention cascade. And we can see, and oops, this example is based on a true example, and we can see how for the testing, the contribution of civil society is very high versus the contribution of the Ministry of Health, in the linkage as well. And then in the follow-up, here is where there is a substantial loss of people followed up, but the contribution of civil society services, provided services, is still significant, although less than those from the Ministry of Health. Well, this is actually, this one is not correct. Here we have those followed up in prevention services. I think this is, the middle one is wrong. And we see the ones that are free at 12 months, and we could actually even know which ones were tested in civil society organizations provided service or from the Ministry of Health. If the funding disappears and there's no funding for these CSOs, then you would expect that all these blue components would disappear because there's no funding. So this is an important argument for the Ministries of Health to actually look for financing to civil society organizations for these contributions. I'm not going to go into all the elements in this slide. I'm just going to mention that in addition to the basic elements of the prevention cascade, which are the indicators in green, we have some other indicators that we're suggesting to monitor the services, the coverage of the services, and the quality of these services. And this is the same for the HIV positive key populations group. Here, I do want to mention one thing that is now has a lot of relevance, and I think you will be encountering. And it is the among these different additional indicators we have here, this is the HIV positive cascade, and we would be disaggregating this cascade by key population. But we have this additional indicator. It's the number of HIV positive detected with algorithms using self-testing, because self-testing has a challenge. You can provide many self-tests out into your community, but you may have difficulties in monitoring how many people are using this self-test, and then actually understanding who of these have turned positive. So the way that we're suggesting is that those that turn positive to self-test would eventually come to your services, right, to complete the diagnosis and receive additional treatment. So, and that would be carried out by our routine HIV case-based surveillance notification service. So we fill in our form of any person that's HIV positive. It would be very important to know if this HIV positive person has used an HIV self-test in the past, and if that is, and if their HIV self-test was positive. That way you can measure how many new HIV positive persons you are fully diagnosed to which the self-test contributed. Because if not, you're just distributing self-test, and you kind of can't gauge how important it is to actually find those additional positives. So this is a very important indicator, and also to be able to accommodate your forms to include that variable. Here's an additional country example, a true country example of a prevention cascade for MSM, female sex workers, and transgender women. I won't go into each and every detail, but just to mention that of the person screened among the total MSM estimate, or among the other ones, are like a third to here 35%, 40% of the total population, which is actually pretty good, because those are the ones that we identify. I assume that a lot of these key populations may get tested through other ways, and that they don't identify as key populations, so the system doesn't collect it. So this in general would be pretty good. Then we would have the persons linked, which is not bad. Like in sex workers, from 3,000 they go down to 2,600, but then to persons followed up goes very, very much down. So that is an important element that this country saw, that they were not maintaining persons in their services when you know that these people have a need for health services, like all of us do, right? So and this in part was related to lack of guidelines, lack of capacity building to the providers and human resources, and also the way these services were being funded, because the services were being funded to find new people. They were not funded to keep those people in services. So that the way the funding was measured and pushed incited in the quality of the services that was being provided. And afterwards, in addition, for example, in these sex workers, of these 50 sex workers, you had one positive. So you had one new infection after 12 months. For MSM, for example, of the ones that continued in care, you had 6.5% positivity among these, right? So these would be people, in this country there was no PrEP. These would be people that probably, if PrEP were being provided, you could have averted these new infections. And for transgender women, the numbers are very, very small. So there was no new infection, but the situation was very similar with regards to maintaining these people in services. And lastly, I want to highlight a little bit of, because it seems that since we go over the prevention cascade, we don't go that much into monitoring of HIV testing services. But this is more and more important as we strive to reach the first 90. So countries, fortunately, are now implementing various HIV testing strategies, right? We have the self-testing, we have assisted partner notification, we have testing by CSOs, we have testing within provider-initiated testing and the MOH, etc. So we want to monitor these efforts, and we want to evaluate them for improvements or changes as needed, because all these different testing strategies, they involve human resources, they involve tests, they involve funding of of public or private entities, right? So it is important to be accountable for the services that are being provided. So here we are promoting this disaggregation of the testing per the different screening strategy to evaluate your positivity rate. So here we have an estimated positivity rate because this table was done to develop targets. But once you develop the target, you're still going to be monitoring it and seeing if your true results are actually commensurate to what you planned. So in this country, actually, the current strategies which were MOH and civil society organization testing was actually getting a very high yield for MSM. I know that this is not the case in other countries. So if you're seeing that this is not the case, then you have to kind of decide what you're going to do with that strategy, what can you change, or if you can maybe reach those people through other strategies. And then here you would have how many new HIV positive people you would have diagnosed. So this is we actually have an Excel tool to help you establish your targets and then monitor them, and which is something very, very new that we're still piloting, but we can share if anybody is interested. We will be eventually putting that on the web as well. So as takeaway messages, something that I forgot to mention is that what we're presenting here can be measured through routine information systems, and they can and should be used for measuring coverage and quality of services for KP. Some of these indicators can also be measured through surveys, but I mean, it could be useful for a baseline, but since surveys are not conducted routinely, I mean, they could be conducted every 3, 4, or 5 years, it is important to be able to measure these indicators in a routine manner. That will improve the quality of the data and will guide you in a more timely manner to reorient your services. The disaggregated analysis can support information on contribution of civil society to KP services, and this is extremely important in this context of limited financial resources for civil society organizations. So we think that and we're seeing that this PAHO framework is a tool to support the monitoring of service delivery models as well. As I mentioned, considering the different models of care is also a disaggregation that can be done. And it also helps to monitor the quality and the results of the services provided for key populations. So it is essential for decision making, for advocacy, and to justify the need to continue these services or to actually for our own quality improvement. So with this, I thank you for your attention. I just want to mention that here are the people that contributed to the development of this framework, and we actually have to increase the number of contributions, because as it is applied in countries, we have now 1, 2, 3, 4, 5, 6, 7 countries in Latin America that are applying this framework, and we hope to see its usefulness for Caribbean countries. But as we apply it, we also have important lessons learned, and this is an important contribution for all of us. So thank you so much for your attention, and we're ready to take questions or comments, criticisms. All is valid.
Thanks, Monica, for the very informative and excellent presentation, and for reminding us as to why we need to focus on key populations, and for elaborating the basic package of services for HIV negative key population groups, which can, of course, as you rightly articulate, can be incorporated into national services, and which is based on the needs of individuals. A gentle reminder that to everyone that you can click on the raise hand icon, and the mic will be released for you to ask your questions. During the time of which you're asking your question, a poll will be posted, and your support in responding to the questions will provide critical information as it relates to the next steps, especially for those countries that are included in the Global Fund multi-country grant for the Caribbean. So now this session is now open to question and answers. As I said, please feel free to click on the raise hand icon. Your mics will be released and you could ask the questions. Timothy, your support with this as well is kindly appreciated. No questions? Everything crystal clear?
Sure. Hi, good morning. Thank you very much for the presentation, Maria. Quick question. In terms of the locations that are actually collecting this data, are the services specifically streamlined for key populations, or is the service being offered as a general service to all persons accessing the healthcare services? Thank you.
That's a super good question. Right now, the way their information system is organized is that this data is only collected within those services serving key populations. As we decentralize services to the primary level of care and serve key populations within general services, it would be ideal to be able to monitor it within those general services. But right now, it's conducted with the monitoring is referring to these specific services.
Thank you.
Any other questions, Timothy? I'm having difficulty identifying the raised hands. Can you assist me, please, and let me know if there are others?
Not at the moment, Sandra.
Not at the moment. Okay.
Mm-hmm.
Is it possible that perhaps we could put the poll at the same time?
I want to mention something that I think is also important for everybody to understand. Sometimes we're encountering very high quality of services being provided for key populations, but these are a little bit like boutique services. They're really great, but very few people can actually access them. So this type of monitoring is going to help us understand if we have these boutique services with a very low impact, or if we actually are attending an important number of need of this population.
Okay, so now the poll, we have 3 questions that are posted through this quick poll, and your support in responding to the questions is greatly appreciated. And feel free if there are any questions during this time. Monica, thank you very much for the presentation. I think it was very excellent. It was very informative, as I said previously, and I am sure that the topic is very important to the Caribbean region, and I'm sure this will be discussed in other forum, hopefully both at the national and the regional level, and that we will be able to see some countries advancing with the monitoring of the prevention services for key population. I think, is it the first poll, the first question that is up, Timothy? Yes,
This
I
is
think
the
it's
second question. The second question, Sandra.
question. Oh,
Mhm.
it's the
Yes,
second
and
question.
also this is not only, it seemed like what I presented is for countries, but we've also assisted several NGOs that provide services in developing their local prevention cascades. And then the care cascades have been done between the NGO and the Ministry of Health, because generally it's the Ministry of Health that is providing the care services, so the treatment and care services. So just to mention that it doesn't have to be at national level. You can have any type of cascade monitoring for smaller geographic levels or just for an NGO. We've produced, for example, a transgender HIV prevention cascade with an NGO that provides services for transgender women. So you can, you know, it's useful also for them to show and to monitor their own services.
Right. Thanks for the clarification too, Monica. And I think I would like to say at this point in time, for any of the civil society organization or ministries of health, if they would like further information or technical support, that they could feel free to reach out to us through their local PAHO country offices. Well, thank you very much. I think we could wrap up the training for today. We have come to the end of this training session, and I thank you all once again for joining. On behalf of PAHO and PANCAP, I thank you for your participation. At PAHO, we look forward to supporting countries, civil society organizations, those who are interested to advance the implementation of the monitoring framework. As I mentioned earlier, for countries that are interested, those outside those countries that are identified under the Global Fund grant, please feel free to get in touch through your local PAHO country offices, and we will be more than happy to provide the necessary technical support to advance this intervention at the local level. Also, please note that the presentation will be shared by PANCAP, as well as the recording for those who were not able to actually join the session, or if you would want to actually listen to the presentation again. Please continue to wear your mask, keep your physical distancing, and remain safe during this pandemic. I'm not certain if we have all the tally for the polls at this time, Timothy?
Yes, all questions have been completed, so I'll share the results.
Yes, please, if we could do that before we close.
The first one is up, Sandra.
Right, so from the first question, we have that 42% of the participants agree that the HIV STI health services for key populations is pertinent to their countries. 58% strongly agree, and I think that is very encouraging, Monica, I am sure. Can we have the next one, please? And we have, is it feasible to integrate and implement within their existing services? 52% agree, 21% strongly agree, and we had others that neither agree or disagree. There again, I think is very encouraging. The last question, please. The result from the last question. And then we have, oops. And of course, we have 73% mentioned that they would like support to develop tools to support the data collection, as well as for establishing the services and for developing the cascade. So I think this is very encouraging. Monica, do you have any last comment that you'd want to make?
Well, just to thank you again, and that we really, 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 really are looking forward to working with you.
Yes, thank you. And I am also excited by the information that we have received through this poll. As I said, we are available, and please feel free to make contact with us either directly through PANCAP or through the local PAHO country offices. So, and we also look forward for the next steps, which are those countries that are under the Global Fund project, to actually advance these countries with the implementation of these interventions for which the training was provided, and it will also include this monitoring framework. Thank you once again for joining us. And
The handouts, Sandra, the handouts.
Oh, the handout. So we will be sharing the electronic copy of the framework, which Monica presented just a while ago. It will be sent along with the presentation. Thanks
It's
for the
available
reminder.
on the control panel, Sandra. If they click on handouts, the handouts tab, it's available right on their control panels.
Oh, so it can be downloaded immediately.
Yes.
Okay.
Yes,
Perfect.
it's there under the handouts tab on the control panel.
Okay, perfectly. And I'm sure everyone heard you. So thanks a lot for that, Timothy. Once again, thanks again for joining. And as I said before, please continue to wear your mask, adhere to physical distancing, remain safe during this pandemic. Have a wonderful day. And I now bring this training to an end. And we will be in touch along with PANCAP with those other countries that are part of the Global Fund project. Thank you very much.
Thank you. Bye.